So obviously today's about ultrasound guided injections. So I'll talk obviously with a focus on that, but there's probably a lot more to it than just the injection itself, or in fact there is. So what I want to do is just talk to you a bit more about how ultrasound guided injections are used within musculoskeletal, and we'll talk a bit more about what that might mean. Pain disorders, so essentially joint pain that can be a trauma to a joint, or it might be a degenerative process to a joint, age processes, or the same with tendons and soft tissues such as ligaments and so on. And we'll look at how, very briefly, how ultrasound generates images, which is relevant because it can be very, very useful in certain circumstances, both from a diagnostic capacity, but also very useful in terms of needle guidance in certain situations. And then we'll have a look at really what sort of treatments you can offer with ultrasound guided injections. And then I'm just going to basically give you a bit of a demo in terms of, in a practical sense, how an ultrasound guided injection would take place. So hopefully that's okay. We'll get going. So this is essentially a slide just to depict, as I've just alluded to there, that it's part of the care package, really, an ultrasound guided injection, certainly in a private clinic like this. Occasionally, I might be referred someone who's on an NHS waiting list, and it's 6 months or whatever, and they've got a clinic letter requesting an ultrasound guided injection of a knee, of a finger joint, or whatever it might be, and we can just pretty much carry that out. But a lot of the time, people have tried some rehabilitation. That might be some osteopathy, some podiatry, or some physiotherapy, and they haven't managed to get the success that they were hoping for, or the clinician was hoping for, and they're looking to see what's wrong from a diagnostic scan. So this is just X-rays are obviously at the top. Everyone knows what an X-ray is. It's really to see bone in good detail. MRI scans can be used for a variety of things. That's probably the most comprehensive type of scan that we can use within musculoskeletal imaging. So looking at tendons and joints. CTs are rarely used, but I've popped it there because they're occasionally used. And the bottom right corner there, you've got an ultrasound scan of a shoulder tendon there. In the middle, you've got someone examining the joint, and that's there for a reason, because actually the way that we're beginning to treat, or it is beginning, I guess, to treat these kind of pain disorders is more from a sort of holistic perspective, looking at what people's movement is and doing a good physical examination, listening to the history, and combining that with imaging modalities. Imaging isn't a picture of someone's pain, it's a picture of their joint or their tendon. And if you imaged my joints, it would probably say there were 42. And so it doesn't necessarily tell you why I might have knee pain or shoulder pain. So it's putting that together with everything in almost every circumstance. And a more traditional background has been this. So you might have gone along to your family doctor, the general practitioner. They might have popped you to a physiotherapist or an orthopedic surgeon. And if one of those clinicians thought it was necessary, they would then refer you for some imaging, and that may be any of those modalities of imaging. But generally, in the past, ultrasound scans have been used far more. I struggled earlier to get an image just online quickly there, so I used one of my, went into my scanning machine and used one of mine. But the of just a musculoskeletal ultrasound image on the software I was using, because they're all babies. So traditionally it's been used for more organs and soft tissue, abdomens and so on, which it's been very useful for. But the resolution of the images with the ultrasound machine has now improved to such an extent that we're now seeing more and more use of it within within musculoskeletal and orthopedic disorders, and that's really why. So the machines and the technology have got better. We understand that it's probably better for some cases because it shows it's certainly superficial structures and certain structures in clearer detail, and injections for obvious reasons are being done more and more with ultrasound guidance. Generally, unless it's a traditional pathway, which you don't see a lot of in the UK anymore, the point of care ultrasound might be done by a specialist physiotherapist or a sports doctor. It might be who's done a training to be a sports and exercise medicine consultant. Sometimes orthopedic surgeons or rheumatologists have learned as well. Now, and this is kind of important because we can then provide a kind of one-stop. You can come in. I've got a referral letter. We can have a chat about your problem. We can have a look at a physical exam, run a scan, and if needed, we can deal with it there and then with an ultrasound guided injection. And that's really what we provide here at Putney Clinic. So this is more my background. Just going back to this, these are a lot of the people. The radiologist is a specialist imaging doctor. Okay, so they've done their consultant training in imaging, and then they would subspecialize into musculoskeletal imaging. They're not trained at more the physical examination and so on, but they're very skilled with imaging. So I come from a different background. More and more people doing ultrasound will. So I did physiotherapy degree. I did my MSc in sports and exercise medicine. Later than that, I did my musculoskeletal ultrasound and non-medical prescribing. And I've been injecting for over a decade, I guess now. So it's putting it all together, really. So I just want to go through this as well. This is important before we come on to the actual injections. There's a reason why I've got this. So what have the left-hand pictures, as it were, got to do with this? This is my quadriceps muscle. This part here is my rectus femoris, and this is the one underneath my vastus intermedius. This is the bone here. But essentially, ultrasound uses waves, sound waves. Okay, hence ultrasound. So it kind of needs something to reflect from. Hence, it's very, very good at seeing certain structures, but we can't see inside certain structures. So we can't see through bone. You'll note that it's very dark here, and that's how we guide needles. Okay. So we'll talk a bit more about this in a little while. But essentially, when I'm guiding an injection in a simplistic sense, I'm trying to hit a target. Okay, so this is a ganglion cyst, this dark area. So this is all filled with fluid. This is just the outside layer. So this is skin, and this is tendon here. And this is the needle here, you can see. So this is a cyst I went into, and I aspirated the fluid out and popped a bit of steroid in it. And in that, you can see the ultrasound probe is kind of here, and the needle is basically coming in through. So I can see the needle at all times. The image, sometimes things are more amenable just because things are in the way and that sort of thing. Sometimes we do what's called an out-of-plane injection, where I'll pop this here. I'll put it directly in the center over where I'm going to hit, and I'll actually come down and through. So you might only see, believe it or not, this tiny little kind of white dot just at the top of this tendon, which is here. That is the needle tip. So you're just trying to get it in place, and it depends what it is we're trying to inject, but essentially it's a real-time thing. So I'm putting the scanner on, I'm holding the scanner still, and I'm guiding it into where we're targeting with an injection. Okay, I hope that makes sense. Just to look at what we can do with types of injections for joint and tendon pain, and this is something which has changed a lot as well. So traditionally, we will have injected corticosteroids with some local anesthetic, and we'll come on to why we're trying not to do that, certainly for some disorders, in a bit. But broadly, in recent years, there have been moves away from corticosteroid injections to sodium hyaluronate and various what we'd call regenerative injections. You probably have heard of platelet-rich plasma, or PRP injections, which we'll talk a bit more. But they have different. They're aimed at different symptoms. Would be the best way of saying it. So, corticosteroids are a very, very powerful anti-inflammatory. And there's two different types. There's not a huge difference in their mechanism of action. It's just that one acts a bit quicker because it's got smaller crystals, so it's easily broken down. And the other one has a longer but less punch, if you like. And we may or may not put local anaesthetic in with it as a bit of a bulking agent, and sometimes we do local anaesthetic on the way down, but generally these are not particularly painful procedures or anything. Sodium hyaluronate is used pretty extensively outside of the UK. The UK doesn't use it anywhere near as much because we are not regulated, but things tend to get driven by NICE guidelines. And at the moment, NICE don't recommend it. It's a far more expensive product than corticosteroid. I can buy a vial of corticosteroid for £2, and these may be £75, £100 upwards. And there's lots of different manufacturers of them. They don't contain, one of them contains steroid. So Singal mixes the sodium hyaluronate, which is essentially a gel substance with steroid. But they're really designed for lubrication and impact. So think of a dry, painful osteoarthritic knee that people are wanting to be more active on and is limiting them. That may be something. And regenerative injections, that's really the holy grail, because it won't have any kind of noxious side effects, or shouldn't have. But essentially, platelet-rich plasma injections is when we spin blood, okay, and we extract the healing platelets. And prolo therapy is just when we inject an irritant, generally dextrose, into the area and cause some inflammation, just kickstart a healing process. And we'll talk a bit more about that in a minute. You'll notice there might be a bit of a so corticosteroids are an anti-inflammatory, and this is pro-inflammatory. So we've got to use the right thing at the right stage. And really, it's going to be about, again, listening to your symptoms, having a chat with you and your goals, a physical exam, and what your imaging shows. And that's probably what's going to, those things are what's going to give us a good indication as to which of these might be best in each scenario. A bit more about the corticosteroid route. So it basically stops cells from producing the inflammatory mediating chemicals. It's not a non-steroidal anti-inflammatory. It's not an NSAID. So it doesn't work in the same way as ibuprofen and so on. Okay. Now, it's a very evident, if you see at the bottom, powerful anti-inflammatory. It works incredibly well for inflammation. And as we've just spoke about, inflammation is fine if you get rid of it, but it is a precursor to healing. So we don't skip from going to an acute injury or any of the regenerative phases. So we're constantly producing new tendon cells, new cartilage cells, new bone cells, and so on. And we don't just skip from doing that. There is an inflammatory component going on to mediate that kind of process. So the problem is, if we keep injecting steroid into things, as we've done in the past, it tends to lead to worse outcomes. It can essentially lead to biological deterioration, because if you keep injecting steroid, it never gets the chance to regenerate. So it's noxious to the tissue. So we used it extensively, as I'm told, in sports in prior decades, and the outcomes after a couple of decades afterwards were not great for those joints. So it should really be reserved for significant flares of joint or tendon sheath pain or whatever, which aren't settling, or inflammatory conditions. And we can talk a bit more about that in a minute, but things like frozen shoulder is an inflammatory condition. So getting an inflammatory injection in there helps substantially. People may have heard a thing called de Quervain's tenosynovitis. You can get inflammation of the tendon sheaths. Often mums get it for lifting babies. They can't look after their babies. It's the tendon sheath and it's inflamed. So things that are inflammatory, it's still used for, and it's incredibly effective. But we shouldn't be using it often for just background pain, or with any degree of regularity for joints and certainly tendons. Just to note, there's also a systemic as well as localized effect. So even if I do an ultrasound guided injection and it's within the capsule of a joint, the body will clear the steroid. Okay, so there is a systemic effect. And so we've done lots and lots of non-ultrasound guided procedures in the past, and they seem to have worked pretty well. That may be one mechanism in terms of why they've worked well. It's more the systemic effect rather than how good we are at getting the placement of the needle in all cases. And I've just put dose versus volume. We basically bulk it out, as I suggested, with some local anesthetic as we need. So we can, if I'm injecting a large joint and I've only got a tiny bit of steroid, because it's a very kind of small kind of volume, it's quite a concentrated medication, I want to bulk it out with some local anesthetic and put them in as a bolus so it gets around the joint. So that's really how we do that. In terms of the hyaluronic acid or the sodium hyaluronate injections, as I say, they're a lubricant and force dampening mechanism, really. So we've got this substance in all of our joints and in our tendon sheaths between our layers of skin and fascia in our body. It helps provide some friction and so on. So we already have this. So this is a significant supplement to that, that we generally recommend for earlier osteoarthritic changes in joints, so degenerative change in joints in younger active people. For that reason, we don't want to be putting steroid in unless we think it's just a flare and it will settle. We don't want to be putting steroid in young joints because it may be deteriorating the joint for the long term. So generally, this is when we use these products. Basically, people tend to do very, very well. The evidence is that it's about in keeping with steroid in terms of the short to medium term effects, but after that, it tends to give people more prolonged relief, and it can be repeated without any noxious kind of side effect to the joint. So yeah, it's a supplementation really. These are generally the products. So Ostenel in the UK is probably the most known product, I'd say. They do a product called Ostenil Plus, which is essentially just a more concentrated version of that. Durolane is probably the second most used product, and they each have certain characteristics so that the manufacturers will market, and there may be some truth in a lot of what they say, but we don't. There's probably a right and a wrong. I was at a conference and someone said there's probably a right and a wrong, but we don't know what's right and what's wrong yet. We know there's something in it. People tend to do quite well, but I can't tell you that synovial or Durolane or Ostenil or Cingal will be better for someone than another product. They're essentially the same material, but they have different molecular chain lengths and so on, which may make a difference in terms of how our enzymes. We've got an enzyme which breaks down this product pretty readily in joints. So it may stay there for longer. And yeah, we don't know which is best really. So just being honest with that. Synovial, this is a new kind of product. So they have what is termed a non-Newtonian fluid form. So essentially, if you for younger patients, so the quicker you compress the fluid, the firmer the resistance. So it's got a very different kind of it's very gel and watery without resistance on it, and as soon as you give it resistance, it firms up. So again, there may be something in it, but we haven't got the evidence to define that yet. And then regenerative kind of injections. So we've got platelet-rich plasma injections, which some people use, and that is we take the blood, we venipuncture the patient, we take the blood, we spin it, we extract the platelets, which are a pro-inflammatory, pro-healing, regenerative kind of part of the blood, and we basically inject it back in under ultrasound to the targeted area. Now, I guess there's heavy marketing in this area, and again, we don't know the full kind of benefits of these kind of procedures yet. If you want things to inflame to heal them, it may make more sense, in my opinion, to maybe put an irritant, cause a local inflammation there and let it do its thing, or you can just dry needle it. So put lots of local anesthetic around places, and for example, where a tendon meets a bone, you'll often get these ongoing insertional tendinopathies. Put some local anesthetic in if you need to, and really basically stir it up to cause some inflammation. That inflammation will lead to the regenerative kind of process. So we're trying to kickstart a healing process. In terms of the big studies done on PRP injections, they haven't really demonstrated, to my knowledge, a huge benefit over other types of injections, and they're very, very costly. So I think we're in the early stage of these at the moment, but there's definitely something in it, in a cellular kind of form. Platelets, these kind of products work really, really well. So, but then when we put them in places in the body, there's probably a gap between how they work in a lab and how they work in the human body when we just pop them in again. So, but this is probably where it's heading for the future. I would say there's certainly something in it. Just put a delay for adequate recovery. You know, if I very rarely do them because there are other options as well, things like shockwave therapy for tendons and so on, which to stir the tendons up, which are less invasive. But when I do these things, I do say to patients, you know, it's not going to be pleasant afterwards. I'm going in with a needle to the painful bit. It won't hurt too much at the time because I'll put local there. But you won't be thanking me for a few days afterwards. It's going to be after that you see the benefits. Yeah. So it's one of those delayed things. So yeah, just coming back to this, how to make a decision on what we're going to inject really. And as I say, it's all about, I've had a couple of patients recently really, really desperate to run the London Marathon. And their knee was stopping them. And I said, ideally, I wouldn't put steroid in a young joint like that. And so, you know, they've consented. The risks are incredibly low. Both got through it, and happy as Larry. So, and then someone else who wanted to get to the end of the football season and it didn't work out for him. So, so it's one of those things that we do things on the basis of your goals. Okay. If you're desperate to run the London Marathon or get through something you have to get through, that's fine, as long as you understand the benefits versus risks and so on. And the big thing if we can really plan, is what is the state of kind of the tissue in terms of, is it an inflammatory issue we need to calm down, or is it a sort of ongoing kind of repair process we need to kickstart, as we've said. So yeah, that's it. How to administer an ultrasound guided injection. So I've got a few props here, as it were. I'm just going to try and move this window over a tad so I can see what I'm doing. There we go. So planning the procedure. So when I scan, and I'll show you how I do that in a moment, but when I scan, I'm gonna see what target it is. I wanna get the needle in, the needle tip in, and you need to measure how deep is it and how far away from the entry point is. Because if you pop a shorter needle in, you're not going to get to it. And I won't mention names, but I was asked about this yesterday by someone who did pop a short needle in and didn't get to the tissue target, and you need to then abort and do it again. So it's not exactly good for the patient. So you need to plan, where is your entry point going to be, what angle of entry, the path to the target. Sometimes there are vessels. Very rarely do we need to contend with any vessels like nerves or arteries or even veins. You can very easily avoid, and so on. Because most of the more evidenced, more worked on injections, we can come in, and it's well evidenced we can come in from an angle where we're away from those structures, but occasionally there's those. So what's the path to the target? And then what am I going to inject? What's the dose and volume, if it's corticosteroid and local anesthetic? And then it's which syringe and needle to use. So if I just show you this, so there are quite a few different needles. Okay, so I'll just give you a brief sort of variety of what we can use here. But I don't know whether you can see that reasonably. Okay, so that's my hand. That's 50 mils. Okay, so 5 centimeters. Okay, and then a slightly thinner needle, but occasionally if I'm doing a hip or something like that, I might use a 60 mil needle, and occasionally I needed a spinal needle earlier today, which was 80 mil, so it's 8 centimeters. So they're fairly kind of long things, but it's also where is also the type of needle, so how thick they are. So I don't know whether you can see that, but the green needle is thicker than the blue needle. So, and this makes a difference when you're injecting certain tissues. Okay, so we've got a really thin needle, which are great. Okay, so these are used in dentistry a lot, these 27 gauges, but it's very very weak. Okay, so if you're going through tissues, and sometimes it bends, okay, and you can't get it through. So it's kind of a bit of experience saying, well, I want to use the smallest, the thinnest needle I can, but I want to be able to get there efficiently. For hands and so on, you can use these tiny ones. For example, I'll show you this. So for hands, you can use these tiny needles there. So generally they'll be sort of more out of plane things. Yeah. So, and then it's just the type of syringe. So what are you injecting? So you can have anything from a 1 mil syringe. Okay. And these are what we call Lurlock generally. So it just fits on just like this. Okay. Easy enough. So you draw up the medication, you change the needle. I'll show you that in a minute. Or you can go all the way if you're injecting a frozen shoulder, for example, and you want to get some good volume in there. You might use a 10 mil syringe. So there's 10 mils in there. It's a lot of volume. Okay. So it's all about picking your tools, really. And again, that comes with a bit of experience, but the biggest thing is planning, because I know exactly which needle I need if I've measured the length and I've planned exactly where I'm going to go with it all. Right, let me pop this out of the way. And then it's really the pre-injection, really. once you know what you're going to do, you're going to draw up the medication. But I need to position the patient. So if I'm going into the outside of the knee, I need to position them in a comfortable way so they're nice and relaxed. And I need to generally, if you can, have the ultrasound machine kind of here in front of you and the patient here. So you're just going in and you can see the needle path very easily on the ultrasound. In certain situations, it's not possible, and you're craning your neck round here, looking on the ultrasound and so on. That's okay too, but it's not ideal at the beginning anyway. And so we sterilize the ultrasound probe. Okay, so we can do that just with some Clinel generally, and we sterilize the patient with some little chlorhexidine kind of wipes, and we use this, which is just sterile ultrasound gel. So this is just the ultrasound gel we normally use, so it's all clean. So I've cleaned the area which is going to have the needle entry. I'll put sterile gel on that. And I've also cleaned this, okay, and that's important. The infection risk is minimal, okay. I've never had one in 13 years of doing injection. I've never heard of one, but I'm sure they do happen. I've read about them. Generally, depending on the study, they're documented about 1 in 10,000, 1 in 20,000, I think 1 in 70,000, I reckon. So it's minimal, but we should still do all we can to avoid it. And in terms of the actual injection itself, so basically what I'm trying to do is, say if my target is on my shoulder here, okay, and what I need to do is get this probe and the angle of entry correct. So what I don't want to do is start off going down like that, because I won't see the needle. Okay, so this is what we need to do. So what I want to do is basically get the angle of entry right, and then it's very, very easy for me. If I'm off at an angle, so if my probe is there, but my needle crosses it, I'm not going to see the needle tip either. So you've got to be careful to see the needle tip. Yeah, and you've got to be careful not to come in at too steep or too shallow an angle. And we can use techniques when it's very tricky and we're injecting very small things. We can use little tricks like I'll show you in a moment if I get a chance. So little like what we call standoff gel. So I'll put lots of gel on and I'll watch the needle come through the sterile gel and so on. But that's really what it is. So communicate with the patient is a good idea. These aren't hugely painful procedures. They're really not. And if anyone is having, occasionally something's going to be sore, generally we can use some local anesthetic on the way down. Okay, it just takes a bit longer for patients. And then the only thing is feel for resistance. So we're injecting, it might be a tiny little what we call bursa. So it may be a millimeter thick, it might be smaller than that. So really what you're doing is guiding the needle in, turning the bevel of the needle a little bit, and then just feeling for when it gives and watching it on the screen and keeping your needle steady as you inject. I always communicate, I generally say to people, right, the thing that everyone says is sharp scratch, right? So now we're in, but then I always tell them, this is the bit that might be a bit sore. It's not terrible. Just when you're there, it's always worth doing that so people don't jump, because generally you won't feel the needle go in and down to the area. It'll just be when you get there and you'll feel it a bit. And that's really how you do it. What I might do is just show you some video examples first. Okay. So this is a elbow. This is a tennis elbow essentially. So the sort of bony prominence you can feel here is this part. Okay, so this is the bone. Okay, and the tendon of these muscles of the forearm inserts into this bone. So this here is the tendon. Yeah, all through here. This part of it. And this patient in particular had a really, really sore, normally right at the end of this kind of bone, so at the proximal attachment here. You see this tiny little defect in the bone here. And it was really, really painful, struggling with work, all the rest of it. You can see it again here. It's a little bit darker, the tendon here. So he's got a tendinopathy. Okay, so the fibers in the tendon are a bit inflamed, and he's got this bony insertional defect, something we see all the time. Okay, so if you scanned my tendons, some of them may look like it, but they can be really, really painful and limiting. This is it from another angle. So if we go back to this angle, the probe on this, to give you an idea, the probe is like this. So at that end of the screen, you're seeing on the right hand side of the screen, you're seeing this, and this is down towards the arm here. But I also scan in what we call a transverse there. So the other image, so this one here, is basically here. So you can kind of confirm what you're seeing in two angles, and this is right at that insertion as well. And this is a very inflamed tendon near it. I'm just going to see if I can change the because I'm just going to come out of this and go in and show you the stop share. I'm just going to go into a folder here just because I don't think they've come out on the slideshow there. So this is the tennis elbow one, which I'll share. So this is the tennis elbow we just showed. Okay, so you can see that I've got the bone now is right over the other side of the screen. Okay, so I've got, because that means I have a very, this is 1 centimeter here. So this is 2.3 centimeters here. So I haven't had to go very far to get to my target. Yeah. If I had the bone over here, I'd have to come under my machine, the whole of the probe, which would obviously not be ideal for the patient. So we can use a really small needle and we can get to it. So if you look at, just need to, okay. So this is the needle path here. So this is the needle, and you see the bevel, the tip of the needle, and I'm just poking at that area and just a little bit of steroid there. And so that is really, it's a good example of, and that's the steroid going in. Yeah. I think you can see that okay. Yeah. So that's what it looks like. That's kind of small ultrasound guided injection here. I'll just stay on here for a moment. I'll show you a couple of other examples. This is a nice, in fact, before we do that, I'll show you can you still see the videos, yeah?
No, we can't see the videos at the moment.
Excuse me. Let's do this. I think you should be able to about now.
Yep, back up.
So so this is an example of just a diagnosis, and then I'll show you the injection. So this is a good example of what I might see on a scan. And so this is the bone, it's a shoulder, and this is the edge of what we call a supraspinatus tendon. The tendon itself looked good, so I went searching because this gent was in a bit of pain. And then path of least resistance, it's just bubbling out. So this is a subacromial bursa, and you just see me just sort of chase exactly where it is. So I'm scanning through and I'm just checking that this bursal fluid here is the subacromial subdeltoid bursa, which you can see it is because it communicates with it. So this is the tendon and the bone. And the injection, which I think you can see here, is in here. So this is where the fluid was down here, but all the way, and you'll see it just distend into this area. Yeah, see that? So that's when you might use a bit of volume and you get some steroid and local anesthetic in there. Okay, and this is the tendon underneath it and the bone here. Show you that again. So it just distends it. Yeah. So that's another good example. There we go. And then something that we can show you. So again, this is a really gnarly big toe joint. So this is the joint crevice. This is me just moving it. This isn't the injection. Just showing you, you know, you can use ultrasound to have a look at anything. And these are all just osteophytes. None of this should just be a smooth kind of transition. This is a big osteophyte here. This is the sort of thing that you get with very advanced osteoarthritis with the joint here. Yeah. That's the advantage that ultrasound can give you. And what I can do is show you, this is what we call an out of plane injection. So again, what I'm doing here is because it's very difficult to access in this plane, especially with all those osteophytes, I'm just basically measuring how deep that joint crevice is, and I'm popping it in here. I'm getting it central, and I'm just popping it in here, and I'm just seeing the needle tip just down here before the injectate goes in. And again, you'll see the joint crevice kind of open up with all the fluid there. So that's the sort of thing that you'll see. So you're definitely in the right place. Something like that would be, I don't want to say impossible, but would be very low chance you'd be able to get in the joint with all that kind of osteophytosis in the way. Almost impossible to get in it, I'd say. And it'd certainly be a lot more painful. This was totally pain-free. And then just a knee. This is a bit of Duralane, I think. I was popping in a knee here. So just to give you an idea, this is the kneecap. So basically, this part is on the kneecap, the side of the kneecap, and this part is on the inside bit of the knee. And what I'm doing is just coming in into this. This is all just joint fluid around here. And you see the needle tip coming in here. So this is femur, so there's a bottom end of your knee, the inside part of your knee, and this is the kneecap, and I've just laid it down. And you'll just see this is the needle tip, straight in the knee, and then you can fill it with a bit of Duralane there. Yeah. I'm conscious that I've been talking, and I don't know whether anyone wants to ask any questions now. Jerry?
Yeah, we don't have any questions in the chat.
That's okay. Fine.
If you wanted to open the floor up, I think that you're quite happy to have.
Yeah. I mean, has anyone got any questions?
Questions.
Hi there, Chris. It's Peter Harris here.
Hi there.
Can you hear me okay?
I can, thank you, yeah.
Hi, thank you very much for taking the time to put that together today. It's been really informative. I really appreciate it, and I find it really interesting. I've got loads of questions for you, Chris, but I'm not going to keep you all night. First of all, you mentioned, about post-trauma and using steroids, which kind of makes sense, which makes a lot of sense. And do you have a kind of a cut-off point? I know people have got to go through the inflammatory phase, but is there a kind of a cut-off point where you'd say, right, okay, now I'll do the injection? So I'm kind of thinking like maybe a twisted, I don't know, maybe 50, 60-year-old with a twisted knee, possible degenerative meniscal tear, and they're not responding to exercises. When would you say, okay, let's try the injection?
I think that is a great example, isn't it? That's something.
Yeah.
Are you a clinician, sir?
I am, yes.
Yeah. I mean, that's the sort of thing we see all the time, isn't it? And I think if you went with a 2024 evidence-based label or listen to some people, you'd basically never help them out, because they've got an inflamed knee. They've probably got a load of joint fluid to tap out because they've got a degenerative meniscal tear. So for me, you need to give them advice at the beginning. I haven't got necessarily a cut-off, I wouldn't say, but what I would say is, I would always say, look, the vast majority of these will settle in a few weeks. And I guess a timeline for that would be, look, I'm happy to have a chat with you whenever, but I would do some gentle physical therapy for 4 to 6 weeks, and basically see if it's going in. And even if it's going somewhere slowly, carry on that path, because this is highly unlikely, if I put steroid in your knee, to change any sort of long-term outcome for you. So that's my take on it. But if after 6 weeks, or even if after, I saw a gent earlier this week, actually, he was in exactly that state. Didn't have a particularly degenerate knee, but in right old state with, he's only 2.5 weeks. I said, look, give it another couple of weeks. It may well begin to settle. But then it's when, well, with a degenerate meniscal tear, is it worth settling it down by popping a bit of hyaluronic acid in, which I've found, again, it's not necessarily hugely evidenced over steroid, but it's not going to be noxious. And people seem, anecdotally for me, to do a lot better than I would have thought with that sort of thing. So, yeah, I give them the option, really.
Yeah, you've confirmed my thinking, really, Chris. I was thinking around about the 6 to 8 week mark, and if they weren't getting any better, then consider a steroid injection then. Secondly, my other question is, when would you not inject? Are there any kind of past medical histories or medications that patients are on that will make you think twice about injecting? When I've spoken to orthopedic surgeons, they're all like, "I would just inject anybody," you know. I mean, there's the obvious, there's the infection and known allergies to it, but in my kind of impression, it's kind of like, it's a very, very low risk, and it is very effective, and there is very little contraindications towards the actual drug itself, the Kenalog itself.
Yeah, look, it's the bottom line is, if they've got a serious allergy to one of the medications, you don't do it. But other than that, or if they have an active infection, so with that I say, are you still on an active course of antibiotics, or are you symptomatic with any infection? Because theoretically it's immunosuppressant. There's a lot about vaccines now. I think, so it just will compromise your ability to respond to them, I guess. But really all of it, other than that, is managed risk. So the big thing with kind of blood thinners, especially like DOACs and NOACs, but the risk of bleed with these sort of things, an ultrasound guide, is so low. So if you look at certainly the papers I've read, it just says manage the risk. And even when I used to inject people when warfarin was used more readily than the NOACs and DOACs. And, you just need to be monitoring their INR, know what it is, and know that they're on a stable dose, and give them informed kind of consent, and say, look, it's going to stop your anti-coag potentially working as well for a few days, just like it will antihypertensive medication and so on. Just monitor it, really. Obviously, if it's unstable or they're going through a program of management, that's when I try and put them off. Because you can inject steroid and a BP can go, fairly high for a few days, or they can have a spike in their blood glucose or whatever. So it's just, I don't want to step on anyone else's toes.
Sure. Yeah, absolutely. And without going into too much detail, the old debate about landmark versus ultrasound. Any thoughts there?
Yeah, I guess, look, I did landmark injections for 6-7 years, maybe even longer. I mean, definitely when you start using ultrasound, you'd never ever go back to doing anything landmark. Now, and I think that everyone who's had this experience has said, having seen how difficult it is to get a needle, and I'm not trying to big up ultrasound guided, it's incredibly difficult to get in some of the target, and I would say it's impossible that you're in the target tissue in some of the landmark guided injections. then it comes back to what's the actual advantage. And I think that if you're injecting the right people with the right medication for the right kind of pathology, actually it will make a big difference.
Yeah.
I think those studies, as we all know, a lot of injections have got done over the years.
Yeah.
And if you're just injecting lots and lots of, osteoarthritic knees and so on, the results are probably going to be similar. But if I'm able to get joints with, that need aspiration of fluid and a really inflamed knees or whatever, I'm pretty convinced if you ran a really tightly controlled study, there'd be a substantial difference. Having done ultrasound, I don't know whether that answers it. Yeah.
Oh, well, Chris, thank you so much for chatting to me. Thank you for the presentation. I really appreciate it. I'll keep quiet now. Thank you.
No worries.
Hi, Chris. There's a message in the chat box from David saying it looks like you're using a wireless probe connected to a laptop. Do you find they are sufficiently diagnostic compared with cart-based systems?
Yes, for most stuff. I wouldn't use it in a radiology department. They're not good enough to diagnose very, very kind of minute kind of things when I need to write just a formal radiology report. So I might get asked a question, just scan a shoulder. I'm not really assessing a shoulder if I'm working in radiology. I'm just writing a report structure. So I wouldn't use it for that. But when I've had a chat with a patient, when I've done an examination like I have with a physiotherapist, and I've done all of that, and I can use these wireless. Yeah, I mean, to answer the question even more, I had a GE Logic R8 before, so I had a cart-based system, and the reason why I chose this one was because of ease and use. So yeah, I had a new one that I bought, and I actually sold it and got this because it once in a blue moon do I think I'd really like something with a bit more resolution and so on. Once you get how to use them, I'm more than happy with it from a diagnostic purpose. Yeah.
Hopefully that answers your question, David.
Yeah, hopefully. But yeah, like I said, it is worth saying, if you go into I think it was the latest GE 10E or something that I was using last year. I mean, the resolution at those hospital-based machines now is unbelievable. But do I see anything differently there than I don't with this? I'm using a Clarius. No, I still get to the same sort of conclusion and diagnosis most of the time. It's like watching a TV in 4K. A massive TV of 4K or a 14-inch, you're generally going to see the same things.
Just following on from that, David has also said, great, which model would you recommend?
For a wireless. So
for wireless, David? Yes.
Yeah, so I mean, these I haven't tried any others, but I did do extensive research before I did. I mean, this is a second generation Clarius, and I mean, it is really, really good. And once there's lots and lots of tools on it, so in terms of focal zones and things like this, that once you get to use, the resolution on it is really, really, really good. So there's I think GE might do a V-Scan Air. I haven't got any experience with it, but those two, I think, from what I understand, would be the ones to have a look at. Yeah, I can if he wants, I can get him in touch with someone who can, I'm sure, do a sort of trial or whatever. Yeah.
Okay. So just from a patient perspective, is there anyone that wants to ask any questions from a patient perspective? One question I wanted to ask, Chris, was what sort of costs are we looking at for an injection?
So basically, a consultation with myself, which will always include history taken, physical examination, and a diagnostic scan. of the area concerned. That was £125. If I do an ultrasound guided injection on top of that, it's another £125. So a full consultation, diagnostic scan, and ultrasound guided injection is £250. The only caveat with that would be some of the sodium hyaluronic acid products. They vary every time I buy them in. I don't make any money off them. I just pass the cost on. They can be anywhere at the moment from sort of £75 upwards. So yeah, that is an additional cost. But yeah, that's really the costs.
Great, thank you. So are you happy to take one more question?
Yeah, of course. Yeah.
Does that, I don't have one. Does anyone else have a question they'd like to put to Chris?
I've got one question. I don't know if you can hear me.
Yeah.
Hi, Chris. It's Clive.
Hi, Clive.
Thank you very much for your time and an excellent presentation. How many times can you inject in any one area, out of interest?
That is a very good question. Yeah, I mean, that's a good question. Generally, patients, it's on the NHS, people have it, they say, well, I can't have more than 3. It's not really ever a consideration. I'm sure I can think of a scenario to disprove that rule, but it's not really ever a consideration, because if it's about the time lag. So if someone's had an injection 20 years ago in their knee of steroid, and 10 years ago in their knee of steroid, and maybe 5 years ago, and now they're seeing me, I'm not hugely concerned acutely at the effects that steroid might be placing on their joint, because it's had huge time lag between those. If someone's had 3 injections close together, you're talking a few weeks by the time the joint is actually able to synthesize the chemicals it needs again and get going with repair and regeneration and so on. So if people have, say, had 2 injections in the last few months, and certainly in the last few weeks, I would say to them that this is not heading anywhere, you see, because it's clearly not working. So I guess what I say to people when I do inject them with that question, I say, look, if this only lasts 6 weeks, basically it hasn't worked. And so it will almost always give short-term benefit. It's how long that lasts for with patients. And so if it's only worked 6 weeks, it hasn't worked. We can't keep injecting at those regular intervals. No. If it lasts 6 months and you're trying to stave off a knee replacement for a couple of years, well, let's get another 6 monthly dose in and another one. So it depends on goals. The only thing I would say with that is if people also have a really highly inflammatory disorder, frozen shoulders, the classic, where occasionally seen people recently that they failed an unguided injection, they failed one guided injection, they really don't want surgery, so we've attempted another one in fairly quick succession, looking at the dosing and everything. Yeah.
Thank you very much.
Okay, we can probably take one last question and then we'll close this session. It's been a fascinating talk, Chris. Thank you very much. One more question or we'll close. Okay, so thank you very much, Chris. That was brilliant. I'm going to end the recording now.
All right. Nice to meet you all.